I'm humbled and honored to give the 2010 Founders Lecture. An even greater honor for me is that last year's Founders Lecture was delivered by my first angioplasty fellow, Dr. Paul Tierstein. And in 2008, this lecture was given by my colleague, Dr. Barry Rutherford, who, along with mentors, Drs. Bob Fry and Hugh Smith, taught me the basics of coronary angiography, or cardiac catheterization, many years ago at Mayo. And years later in Kansas City, it was my privilege to teach Dr. Rutherford to perform coronary angioplasty. And in 2007, at this meeting, the Hildner Lecture was given by another, what we called Advanced Angioplasty Fellow, Dr. Greg Stone. So, with little doubt, these gentlemen and many others have conferred success upon me by confirming the adage, if the pupil is not greater than the teacher, then the teacher has failed. I didn't fail. Got some great fellows out there. Although founded in 1978, I didn't become a fellow in the then SCA, as you can see there, until 1987. However, over 31 years ago, actually it was in April of 1979, I attended the 6th annual refresher course in cardiac imaging on Hilton Head Island. Maybe some of you were there. This was sponsored by the North American Radiologic Society, which was kind of the premier group at the time, as the SCA was still really unknown. And at that meeting, I was privileged to meet both the founders of the SCAI, Drs. Mason Sones and Mel Judkins, who were being honored for their legendary contribution to cardiac catheterization. A lesser memory from that meeting was an afternoon's impromptu entertainment that was given or provided by cardiologist Dr. Butch Harbold. Maybe some of you remember or know Butch, who performed death-defying feats in his stunt airplane out over the Atlantic Ocean right beside the hotel. That's the way it was in those times. So let's commence by briefly reviewing the standards of care for patients experiencing acute myocardial infarction in 1980. The nexus between AMI and coronary angioplasty may seem obvious to you in 2010, but it was anything but that in 1980. When I started medical school in the 60s, we treated patients with AMI, STEMI to you, AMI to me, with observation, primarily in a hospital bed in those institutions that had coronary care units there. Had very little to offer them. They were treated with morphine, oxygen, and warfarin, as you can see there. The big thing was we kept these people in bed for 4 to 6 weeks in hospital, and coronary angiography was not performed. Now in the 70s, the big change was hemodynamic monitoring. Willie Gans and Jeremy Swan introduced the Swan-Gans catheter. It really changed what we did. It gave us the ability to adjust and monitor afterload and preload and all those things, trying to preserve myocardium. Gave lidocaine for arrhythmia prophylactically then, coming to vogue. Patients still got warfarin, mainly because they're still in bed for 2 to 3 weeks, and the great concern was actually deep vein thrombosis. It wasn't given because of, not necessarily because of intramural thrombus, but the concern about DVT. Coronary angiography was still not routinely performed in these people in the 70s. It was really limited to folks who had developed either structural defects creating hemodynamic compromise, and those that had ongoing refractory angina in the setting of a recent MI. So bypass surgery was really limited then to those folks and was not routinely performed. Now, at the bottom of the slide, I say the role of thrombus was uncertain. Now, by that I mean thrombus is part of the pathogenesis of acute MI. I know that's hard to believe, but in fact, it was so. However, 79, 80, things were changing. And one of the papers that really changed that and got my attention was this one by Marcus DeWood. We were aware of his work a year before based on abstracts, but this was a seminal publication where he showed that 88% of patients who had angiographic features of thrombus during the acute cath, during an AMI, 88% of those folks had that thrombus retrieved by a Fogarty catheter at the time of surgery. They took them to bypass, put a Fogarty up there, and they pulled the clot out. So pretty convincing. The thrombus had a role in AMI, and along with paper on the same time, Peter Entrop, a small paper overlooked by many, but he reported that 4 out of 5 patients with AMI had improved distal flow with intracoronary streptokinase. Again, got people's attention, and a handful of centers commenced investigating intracoronary lysis, and particularly this is a notable one by Willie Gans, as he's the first author there, Intracoronary Thrombolysis and Evolving Myocardial Infarction in Man. Willie and a whole host of really noted co-authors there described opening 8 of 9 totally occluded arteries, but with significant residual following lysis. But Dr. Gans concluded that intracoronary thrombolysis appears to be a safe, effective method for rapid non-surgical reopening of the acutely occluded coronary artery in developing AMI. It sounds like a big deal, and it was. So because of this, again, a handful of centers were pushing the forefront with intracoronary lysis. By that time, I was at the Mid-America Heart Institute, and over the course of 2 years, we did intracoronary graft lysis to a couple hundred patients. But this is one that's pretty notable. When I checked it, you see why I'm showing it. In August of 1980, this patient presented 3 weeks after bypass surgery. Wow. With a stuttering anteroseptal infarction. And what you see there is a big filling defect, down here at the adjacent to the surgical clip, the LAD. And of course, the real question is, why did the surgeon do a internal mammary graft? But that's kind of the way it was in many centers. So after 60 minutes of streptokinase, that thing is gone. It was absolutely normal, pain relieved. The patient did well thereafter. It was astounding. But this was a rare result of intracoronary streptokinase infusion. Now that you understand the standards of care and the atmosphere around during the 1980s around acute infarct care, let's talk about what we came for, and that is percutaneous transluminal coronary angioplasty, or PCI to you. And we'll start by looking at this picture. I think very few of you have ever seen this. In October 1979, I was a young staff cardiologist at the Mayo Clinic, and a patient was referred to me from Waterloo, Iowa. And this gentleman had unstable angina, couldn't work, and et cetera, as you'd expect from this lesion. And the referring doctor was a cardiologist and was aware, as many of us were, of course, that Dr. Grunzig had been performing balloon angioplasty in very limited fashion, but a great technique. And this fellow thought perhaps we were doing it. Well, we weren't, but it so happened I had 2 Schneider-Mendentag left French, or 11 French left guiding catheters. That was the first guy I'd ever made. And I had 2 3-millimeter Grunzig balloons handmade by Schneider-Mendentag. He's been in the lab for 6-8 months, as a colleague had made the trip to Europe and brought him back. The day before attempted a procedure in this man, I took 1 guide, 1 balloon, and I worked out the technical aspects in actually a large St. Bernard dog, of all things, and actually could never hook the left coronary artery. Just the way it was. So on this day, however, we set out to do angioplasty, and a lot of other things I could relate I'm not going to bore you with, but it took 2.5 hours to push that balloon, very high profile, poorly performing balloon, through that stenosis, 2.5 hours. But it did cross, as confirmed here, and what that is a contrast injection through the distal side holes of this 2-lumen balloon. It didn't have an end hole, but a couple side holes, and the only way we could see where these balloons went was by injecting dye through the balloon. You could not inject it through a guide for reasons that will become very clear to you. So the balloon crossed and blew it up like so, got a great result. Isn't that nice? By the way, that lesion never restenosed. This man was studied 12 years later, had new lesions elsewhere, were dilated. He lived another 30 years after that. So quite a success for the first case, but let me further add, in those times, a real issue, largely promulgated by Dr. Grunzig, was that we had to measure a gradient across the lesion. You had to do that. So that's what this demonstrates. Here's with the catheter across the stenosis. You know, the distal pressure's low, and you do a little pullback, and of course it comes up. Now, after dilatation, we achieved that kind of result. Looks far from perfect, doesn't it? But you know, it was, and I want to show you another slide I think that I've perhaps never shown. At that time, I had a pulmonary artery catheter in a patient, a lot of other devices, and also put a Wilton Webster thermodilution coronary sinus flow catheter in the coronary sinus, figuring that if this thing worked, we'd see some increase in the coronary sinus blood flow. And in fact, we did. You know, here's a baseline level down here of 155 mils per minute flowing toward you in the coronary sinus, and after angioplasty, we let the balloon down, got some recovery, and it came up to about 198. So, fantastic. Allowed me to write the first paper I ever wrote about coronary angioplasty, which is coronary blood flow responses during successful PTCA, published in January 1980. So in 1980, the term PCI, which you all use today, was non-existent. In fact, we called everything balloon dilatation. And around that time, some wag came up with the term PTCA, which then, we continued using, especially that you're all members of. Interventional cardiology was non-existent, non-existent. Cardiovascular surgeons, all cardiovascular surgeons, and many, many cardiologists were in strong opposition to this procedure, particularly the academic cardiologists, for reasons you can understand. And the indications for angioplasty were exceedingly restrictive. And you'll see that on this slide. Dick Myler, Richard Myler, one of the early godfathers of this procedure, sent me this slide in 1980. It says, here you go, the indications are single vessel disease, lesions that are proximal, concentric, discrete, non-calcific, subtotal, something you never see, rarely see. Patients had to have failed maximal medical therapy, and the patient had to be a candidate for bypass surgery, standby. And that requirement alone in the early years added a lot of complexity to attempting to do angioplasty. But again, with these criteria, still at Mayo, jumping back a little, in April of 1980, the perfect lesion arrived, proximal, concentric, all that business. And here it is. So what do you do with that? The indications, contraindications, and all that hadn't been worked out yet. Remember, in those times, I had done perhaps the 120th angioplasty in the world, kind of that range. No one had really dealt with these things. So it was a pretty easy matter to stuff this balloon in there. Now we're down probably to 9 or 10 French, as Bard was making the guides, and Grunsig balloon now made by Bard. So got a great result, didn't we? Fantastic. This patient's symptoms, a 40-year-old man, symptoms totally relieved, did great for 5 months, reached the nose, had bypass. We learned something. 1980 imaging was abysmal. We used, really high exposure, low resolution X-rays, 35 millimeter film, and I'm going to show you several actually that you'll recognize the differences. We didn't have flat panel displays. Digital imaging was non-existent. Didn't have biplane fluoro, C-arms, LUCs, none of that stuff. Typical cath lab, put the patient in a rotatable cradle that was positioned between a stationary X-ray tube below and the image intensifier above, and then we'd roll the patient from side to side to get the different angles. And we looked at these images on real low resolution cathode ray tubes, television sets that were, really crummy. And most of the time they were positioned across the room. We learned you had to put them on a cart, bring them up and look at them, trying to really make sense of it, but difficult. Equipment choice was really easy, quite easy, because we only had one guide, and that was the 9 French left Judkins made by Bard. In 1980, we did not have a right Judkins catheter. Isn't that amazing? We had something they called the FRS that had a most unusual shape, and in my hands could never engage the right coronary artery. So we made our own. We made our own right Judkins guides. It's real easy. You take the left guide and put it over a steam kettle, which puts some heat out there, soften up the secondary curve, and you could open the end of the catheter so it looked and performed like a Judkins, the right Judkins. Interestingly, we used 0.63-inch wires that came with the system, to introduce the guide catheters in the femoral artery. Now, this is a big piece of metal, stiff, and caused quite a bit of mischief. And I reviewed a case, fortunately I hadn't done it, but where that wire actually entered the subintima and the femoral artery, dissected the entire aorta and aortic arch around to the coronary ostium. And we had the non-steerable Grunsig balloon catheter. That was it, pretty easy to pick equipment. We also didn't have hemostatic valves on sheaths. Now that's really a big deal. Just pay attention to that. We didn't have over-the-wire steerable balloon catheter systems. We didn't have non-compliant balloon materials. We didn't have high-pressure balloons. We didn't have vascular closure devices, filters. Didn't have atherectomy, rotaritors, all that stuff. Stents were not yet a figment of anyone's imagination, so pretty simple. Now there it is. I took this picture in the lab, Mid-America Heart Institute, 1980. This is the Grunsig called 2030G balloon. And there's a 3mm polyvinyl chloride balloon that was highly compliant, like a kid's balloon. More pressure, the more it would expand. Notice the tip, there's about a 1 centimeter stiff spring wire. You would be appalled to have this in your hands today. A couple little side holes right here that connected to one of the dual lumens, and that allowed us to measure pressure and also inject that dye you saw going ahead. And then notice these gold bands here, is one at either end of the balloon. These gold bands were glued and crimped onto the catheter. These were shipped unsterile. Before we did the procedure, we soaked them for 30 minutes in a vat of Sidex, which was an antiseptic at the time. I have no idea if that's still around. But, Sidex would sterilize these things, but it also dissolved the glue that held the gold bands on. And we learned that the hard way, and for many years I had a patient in Kansas City walking around doing fine with this gold band in his distal circumflex system. Now, I don't know what the price of gold was then, but today I would have had to charge him more to done this procedure. Now, when you inflate these balloons, this is the 3 to 4 atmosphere inflation. They typically would assume this banana-shaped configuration. And if you inflated it to 5 or 6 atmospheres, it would always break. And when they broke, they blew up such that you could rarely pull them back into the guide catheter. It was complicated getting them out. And also look at the size of the guide here with a flared tip instead of a tapered tip, for whatever that's worth. Now this is an interesting setup here. There's actually one feature that's important, so look for it. This glass control syringe here was used to inject contrast through the lumen of the balloon so it would come out the distal holes here, end holes, you can see where you were going. This syringe was used to inflate the balloon, and notice here's a pressure manometer, if you will. Bought that in a hardware store. It's a tire gauge. And then later they made them. But what's glaringly absent here is a hemostatic valve at the back end of the guide, which didn't exist. And consequently, as we did these procedures, blood constantly dripped from the back end of the guide, saturated the field, and in long cases, which they all were, ended up soaking your pants, your shoes, your socks, pretty messy. So that such a simple thing as a hemostatic valve became a great invention. We didn't have these things either, thrombin inhibitors, P2Y12 inhibitors, 2B3A inhibitors, and even this slide's incomplete because there are many more. Again, these were the figments of someone's imagination. What we had was this: procedural pharmacology. Patient on the table was given an Iserdil tablet beneath the tongue. Some of us would use Dextran too. A Dextran infusion was used in a weak attempt to impede platelet function. But we give a bolus of 5,000 to 10,000 units of heparin, and then after the procedure, reversed it with protamine. That led to a lot of exciting events in the cath lab, and helped us, realize we need to leave something in the leg, and let the heparin wear off, that kind of business. But that's our antiplatelet regimen. Boy, that was it: aspirin and Prosantin, dipyridamole. But we couldn't give that until after the procedure. Why is that? The surgeons at that time would refuse to operate if the patient had been exposed to aspirin. So we had a successful procedure. We gave them aspirin and sent them to the room. The first 50 patients that I did at Mid-America Heart Institute are shown here. And there's just a lot of interesting information here. Well, let's look at this. With this equipment and setup I just told you about here, 98% of these people have single vessel disease, consistent with the rules. 28% failure rate. Sent 8% to urgent bypass, had 12% that were seriously complicated. Another 12% later had elective bypass. Why in the world would you do a procedure like that and continue doing it? You know, we got better, we got better devices, got experience, et cetera, and halved all those bad rates to the next 100. But now that I've prepared you, I've prepared you for, you understand acute infarctions in 1980, and you kind of understand the status of coronary angioplasty. I'm going to tell you about the first primary angioplasty. The reason I can't show you a film is it's long gone. What a tragedy. I've spent much time trying to discover it's long gone. But basically, we had a middle-aged man that was admitted to the hospital with unstable angina. He was cooled off for a couple of days, which was a routine. I don't remember for sure at the time what it was. It probably might have included heparin, thrombus issues, but not, probably was heparin and oxygen, bed rest, all that business. He had a coronary angiogram that showed this perfect lesion in the mid-right coronary artery, everything else being normal. It was, 95 tight lesion, good, still flow through it, decent flow, it was concentric. So it was located near the junction of the proximal with middle 1/3, reasonably proximal in the right coronary. So he was placed in my schedule for angioplasty the next day. As I'm working in the laboratory, the nurses called me from his floor and said the procedure's canceled, but it was actually fairly common at those times because people would infarct in hospital. They'd be admitted with unstable angina, go ahead and have their infarction. But he's having acute inferior infarction, been going on for about an hour, ST segment elevation, inferior leads, diaphoresis, even bradycardia, severe chest pain, and procedure was canceled. So I thought a few minutes and thinking, what could have possibly transpired in these last 24 hours that would change him from a perfect, if you will, angioplasty candidate to now something else. So I had to bring him to the lab anyway, pushed him down there and injected the right coronary artery. It showed total flush occlusion of the right coronary. And he's with severe pain, ST's up, real sick. Oh, it seemed to me again that a day ago he was a candidate, so I decided to push a 20-30 G balloon into this stenosis. It actually sailed through. It just went through like that. Inflated the balloon a couple of times. Artery was wide open, chest pain totally gone, ST segments back to normal. It was the first time I, or perhaps anyone, had seen that event, which was seminal and influenced me, and maybe you, quite a bit. This is not that film, but it's one from the same time period, which shows the limitations of the technique. This patient who's presented with an acute anteroseptal infarction. Now these are, this is 35 millimeter film. This was converted a number of times. Notice that total occlusion of the LAD here, a little slow flow or maybe collateral flow into the LAD. It's been, improved as best we can to make it show. But this is how we visualize. See, we're injecting dye through those distal side holes, and of course it's all going into that diagonal branch because these are non-steerable. You can even see the wire in the diagonal branch. I had learned by that time to bend that thing. I had developed a way to angle it so I could get a little steerability, and having done that, we're now selecting the LAD proper. Now here's that distal injection showing us where we are. And unfortunately, the balloon was too small, but we didn't know those things at that time. It was probably a 2 millimeter balloon. We only had maybe 3 different sizes, but injected the vessel, and man, it's got some patency restored, certainly a suboptimal result by everyone's standards today. And even then, it seemed, well, that's not good enough. So, the logical approach even then was to recross it, which we always did, and recrossed it with a little larger balloon and inflated that thing, and actually achieved this result, which was spectacular for the time. Now, you'd stent that today, but didn't need to then. Couldn't. But relieve the patient's pain, symptoms, the whole business, and that's how it was done with these crude catheters in those times. Because of these experiences now that through 1980 you're seeing, in the fall of 1980, my colleagues and I, including Dr. Rutherford, Dr. McConaughey, primarily those times, Dr. Warren Johnson, Dr. Lee Georgie, we created something you'll never see again, a one-page consent form. Isn't that spectacular? And here's the first half of it. Dr. Joe Babb, right, agreed to undergo heart catheterization and receive infusion of blood-thinning medication and streptokinase directly into the heart's arteries, attempt to open a blockage. Additionally, I agree to have balloon dilatation, coronary angioplasty. If arterial narrowing performed is judged appropriate by my physician. Look at the latitude the doctors actually had in caring for patients. I understand that after the initial coronary angiogram, my physicians may decide that it would be in my best interest not to proceed with any of these things. That was it. And they signed that and we're happy for it. So let's look now at, we're evolving into 81, and lysis is growing in some centers. Few are doing angioplasty, very few. Patient presents with acute inferior wall infarction. Poor film, again, 60 frames a minute, 35 millimeter film, low resolution. Marked hypokinesis of the inferior wall, and I believe this patient had experienced a previous anteroceptal infarction, so you saw the dilated ventricle. And interesting, this huge acute marginal branch collateralizes the LAD, but here the right coronary is totally occluded distally. And by late filming, a little backfilling from the LAD, I could put some dye back into the posterior setting, posterolateral segments, showing you there. 30 minutes of streptokinase. What's going to happen? Most of the time failure, but here, of all things, it opened. Now look at that. However, there's this mobile filling defect just distal to the stenosis. Again, this is the rule rather than the exception, finding this kind of anatomy after streptokinase. So at that time, the only logical thing to do was put a balloon in there, get a non-steerable Grunson balloon, dilate the thing, and achieve this result, which by your standards today is suboptimal. But we didn't have bigger balloons, didn't have stents and all that business. We had good flow, patient symptoms relief, so we stopped. Restudied him a couple of weeks later, which is our rule then. After these PVCs, you'll see pretty marked improvement of the inferior wall, which is something that we never saw with streptokinase alone. Never. It required full restoration of patency to achieve that result. Middle of 81 here, I'd accumulated actually 16 patients. My colleagues and I accumulated 16 patients. We'd used angioplasty for acute infarction. I submitted it as an abstract and presented it here at the March sessions. What you see here is that I was able to conclude that the urgent angioplasty with and without intracoronary strep relieved pain was, generally a good thing. This was actually met with quite a bit of controversy. A few months later, I got this letter from the Veterans Administration Hospital in Ann Arbor, Michigan. And the author said, "I'm writing you today, thank you for the opportunity to observe your current techniques." And he wanted to tell me why he had interest in this field. So he's a member of the cardiology staff, U Michigan. He's worked with Dr. Joe Walton. He'd done 15 procedures and participated in 5, and therefore was an expert. Who do you think wrote that letter? You got it, Bill O'Neill. The amazing thing is he misspelled my name 3 times, and just right there. So, by the end of that, a little further along that year, we now accumulated 78 patients with AMI, used angioplasty in all, 29 alone, and was able to conclude that PDCA is definitive therapy for acute myocardial infarction. Now, I don't want you to think my only interest for acute infarction, and here in October 82, in the angioplasty section, there are only 10 angioplasty-related abstracts. In 1980, there were 4. There's now up to 10. And we're speaking about things like this: recurrence of stenosis after successful PTCA. But I presented an abstract entitled "Simultaneous Multiple Lesion Coronary Angioplasty, a Preferred Therapy for Patients with Multiple Vessel Disease." Obviously a somewhat insane title for the time. Dr. Grunzig and Dr. Myler took great umbrage with this presentation. And I recall to this day watching Dick Myler walk from the back of a room that's about 4 times this size down the middle to the microphone, where he criticized me roundly, soundly. His final words were, "Geoffrey, if you push angioplasty, it will push you back." It probably did. However, in fall of 82, these folks showed up in Kansas City for a symposium we put on angioplasty. This is Dr. Gans, heavily invested in lytic therapy at the time. Andreas Grunzig, for those of you who haven't seen him. My colleague, Dr. Barry Rutherford, in younger years, and a young me. Barry and I presented our work with complex and multivessel angioplasty, but particularly acute infarction. I'd have to say that Dr. Gans took it well and was supportive. Andreas, too, but was very cautious and conservative publicly. Privately, he actually was encouraging. So what happened over the rest of this time, you know, the 1980s? Well, the Mid-American Heart Institute group, we, you know, a bunch of manuscripts and abstracts. Interventional centers slowly started adopting direct angioplasty, but the big change was here, 1984 to 85. A sea change occurred in coronary intervention that made this procedure much more available. This is a patient with acute infarct in April of 1985, presents with acute inferior event. And you're going to see, obviously, the right coronary totally occluded, but now a different approach. We're going to come after this stenosis with the finest steerable guide wire ever made, the first one, an 018 high torque floppy guide wire. So here comes kind of a real-time presentation, guide wire. You see we probe this stenosis a little bit and try and find the weakness, and popped it through here in just a second and take it distally. And now we're going to approach this now with a 3mm Simpson-Robert balloon catheter, high-profile device. Notice it won't cross. We use the guide, as we learned to do, to stuff it through and dilate the lesion, and ends up being underdilated, come back with a little larger balloon, and you have a decent result. Could have even been larger. You see some haze there, a little split and crack and all that, but considering the circumstance, it's not too bad. Restudy this patient, you know, a few weeks later, and again, some PVCs here, and then notice the inferior wall is markedly improved. Again, we never saw that with lytics alone. We only saw that when angioplasty was involved. Question is the right coronary open? Sure. Yeah, in fact, it might be a little better. The power of healing, I guess. Now, so enthusiasm for lytic therapy continued in the last half of the 80s, particularly when the recombinant tissue plasminogen activator was invented and came available. And the thought was that one could systemically administer the drug, you know, and prevent need to cath folks. Unfortunately, the TIMI-2B trial, I don't know how many TIMIs there are today, but the TIMI-2B trial was misinterpreted and challenged the role of angioplasty. And I frankly believe it set direct infarct angioplasty, primary angioplasty, back by about a decade because of the need to combat the lytic enthusiasm. Since I had used both, I was using both lysis and angioplasty. I was invited to sit in a panel at one of the big national meetings, Anaheim, 1990. All the lytic experts were there, and I guess I was maybe part of that. And came around to the panelists, were all asked this question, came to me finally, and my response was rapid injection of 100 milligrams polyethylene on a balloon catheter. So now, ordinarily, since time is up, I would stop there, but if you want to see, devote another 5 minutes, I'd like to show you a film that will mean a lot to you. And the slide immediately before that is this one. Also very interested in multivessel angioplasty, you know, attempting to create a complete reperfusion of these folks. We published a bunch of abstracts, manuscripts, book chapters detailing it, but here is a typical case. I found this in my archives. It had a label on it that said just classic multivessel angioplasty case, 1985. What do you think? Pointing out a load of lesions. The reason being that wasn't sure we could see them on this old film. So let's look at the LAO cranial view, also highly subtotal lesion, diagonal total occlusion, the LAD. You can see the prox circ lesion quite well there. And this straight RAO view, kind of hard to see, but shows again all these circumflex lesions plus the occluded LAD, high-grade diagonal lesion. And of course, that's the, I believe this fellow with the RAO caudal projection, one that was fairly useful at the time, but doesn't project well, although you can see the lesions there too. This patient needs surgery, doesn't he, Chris? Yes. RAO cranial view shows the total occlusion of the LAD up there, a high-grade diagonal lesion, and pretty long, 2+ centimeter long total occlusion of the LAD. Thank God the right coronary is normal, right? Well, it's totally occluded too, and there's a high-grade lesion up there, so. So what we're going to see now is a procedure using 018 high torque wires and Simpson Robert balloon catheters. And let's see if we can turn this sow's ear into a silk purse. Proximal and distal dilatations, recross. Not too shabby, huh? Not too shabby. But that was easy. That's just straightforward stuff. Total occlusion, no big deal, but pretty good. You'd probably be proud to have that artery in your body, right? So let's look at the left side and see what happens. Proximal circumflex, big balloon, distal circ, obtuse marginal, diagonal branch, stiff wire across the total occlusion, followed by floppy, small balloons to dilate what proved to be diffuse disease through that segment. Diagonal branch. Wow, not too bad. Considering that this was done in the non-stent era. I think the left views, confirm what we suspect, but things are in good shape. The LAD diagonal system seen in this LAO cranial view, widely patent. So that kind of work was being done in 1985 in the absence of all of the drugs that you have today, in the absence of stents and alternative devices. And I think can encourage you to do more. It's been my privilege to talk to you. I wish I had 2 hours, as there are a lot of stories I could tell, but I appreciate your patience.